This is Wealth BT, a podcast of BT correspondents.
Something is brewing among private hospital integrated shield plans. I wrote an article in the Business Times in July about a partnership between IHH Healthcare and two IP insurers to try to dampen private hospital bills. IHH owns 3 hospital brands, Gleneagles, Mount Elizabeth, and Parkway. It has 60 to 70% share of the private hospital IP claims. As you know, the cost of private hospital IPs has escalated over the years. In fact, premiums of base plans and riders have risen almost every year. What does this partnership involve? How effectively can it help to dampen claims? Could these efforts to control costs have unintended consequences for policyholders? Welcome to Wealth BT, part of the BT Correspondents family of podcasts. I'm your host, Genevieve Cua, Wealth Editor of the Business Times. With me today is Jeffrey Law, Chief Commercial Officer of IHH Healthcare Singapore. Thank you, Jeffrey, for joining us at the studio.
Thank you, Genevieve.
Let's recap this latest development in private hospital IPs. So what were the concerns of IHH and how did your partnership with IP insurers come about?
I guess as an anchor player in the private healthcare space, it's to our best interest that the ecosystem develops healthily and sustainably. So maybe to take us a little bit back to, say, 10, 15 years ago, we have asked the private hospital facilities, you have the insurance payers, you have the specialists, and we are all sort of doing our own thing. The payers were redesigning products. You have all kinds of different products of shield that came through in the last 10, 15 years. We as a facility focuses on the infrastructure, wanting to develop better quality care to members and to patients. And the specialists come into the private sector after decades of experience in the public healthcare systems, come in and wanting to make a difference in their practice as well. So each of us has our own proposition and there's some peaceful coexistence, honestly, for quite some years. Until I would say towards the turn and coming to 2020, 2019, where there's some stresses that start to appear in the system. So if you start to look at the IP insurer, there's conversations that the profitability are being very challenged and different insurers are starting to rethink about how do they manage some of these claims a bit more effectively. And for us as well, I mean, post-COVID, you realize there's a huge medical inflation. It's driven from many, many factors. There's manpower, there's utilities, there's all the cost drivers that drive healthcare that is increasing at a rapid pace. And for us as a player, when we look at that, it only works for us if the whole system is healthy, is peaceful, is sustainable. But once the tension and this friction occurs, then we realize that it's probably something that we need to look at seriously and see what kind of role we can play actively to sort of bring everything together.
So how do you work together? I mean, you have 2 insurers now on board and they've been there at least 2 years now. That's Singlife and Income Insurance. So what made you actually take this step?
It took us a while to form some of these partnerships. Between the different players, there is somewhat a deficit of trust because you look at the commercial interests and all those things, they seem to be pulling apart from each other. So it took us really a long time to come to terms on what are the right partners. And for the insurers as well, I think we keep active conversation with all our insurance partners because we think it's something that we want to do that should benefit the whole system. So we spoke actively to all of them and everyone has a slightly different business challenge. So it took us close to 2 years to have the first partnership going. I think that was Income and following very shortly, Singlife came on board. But it just needs that period of time to come to some understanding on what we can do for each other.
So you use a third-party administrator, which is your own, which is iXchange. So how does this work? And what metrics do you particularly look at?
So iXchange has been with IHH for a long time. If you recall, many, many years ago, IHH even have an insurance business called Shenton Insurance. And iXchange is a TPA that works with Shenton Insurance to really look at a corporate health business. So to some degree, iXchange have some experience in managing costs because in the corporate health insurance space, there's a huge emphasis on that. So there is some experience from iXchange to do this, but it has been very focused on corporate. And when we look at how to evolve ourselves within IHH, what is the best sort of entity we can use to have those conversations with insurers, iXchange came about as from our point, the most visible platform and most viable platform for us to have those conversations with insurers. But we also need to fundamentally retweak the iXchange model, because the shield business is very different from a corporate business, right? Where a corporate business, there's usually a pathway of care from primary all the way up to tertiary care. While in the shield business, which is fundamentally a retail business, you see more patients walking into specialists themselves out their own, and the whole rules of shield is very, very different from the corporate. But fundamentally, the essence of it is about cost and value management, which we think we can transplant that model slightly to support insurers as well.
So part of iXchange role is to act as the gatekeeper for letters of authorization. And so how does it do this? And in the process, what factors in particular that it looks at to decide, for example, what is medically necessary versus maybe less necessary?
I would say iXchange being within the IHH system is somewhat integrated in the way we have operated. He has a more effective role because, take for example, at a pre-admission level and before the patient is admitted, you will typically have financial counseling. You will have a system where specialists can lock in the cases with iXchange to say, hey, this is a patient and this is what services will likely be performed. And we will have, within iXchange, after the years of operating this, we'll have some level of data and insights. So before the patients enter the facilities for their treatment, we will already have a pre-conversation with the doctors around what the patient's treatment is for. Some data points will be keyed in, and we will have our own clinical team that we build specifically who can speak the same language with doctors, understand our system well, understand private healthcare well, and be able to sort of empathize with what the patients need and what the doctors need. So we have very productive conversations around that to make sure that everything is appropriate and the right services will be rendered. It's not overly aggressive in treatment, etc., and it's the right side. I think, for example, if we think that this surgery should ideally be in a day surgery center, which means patient doesn't need to stay overnight, we will have a discussion with the doctors, and in most cases they will agree, or they already are planning to put on day surgery services. So we have those early conversations prior to the patients coming into the facilities, and that helps to at least make sure that the patients are right-sited, there's some appropriateness of care that we are looking at.
So in this whole equation, there are many variables. There's facility fees that account for cost, specialist fees, consumables, medication, and so forth. What factors are within your influence that you can most influence versus less influence on?
I would say most of it, honestly. If you look at what we mentioned just a while ago was about pre-admission, but you also have post-admission. That means the patient is about to discharge, and we are consolidating the bills. We're looking at the whole charges, and we will also have another gate at that point where we support the system, the doctors, the patients to make sure that everything is appropriate, and we can then put them through. In the past, I think for most insurers, we will just file the claim without some form of oversight. So the iXchange team do a pre and then do a post reconciliation. And if there's anything that we need to discuss with the doctors to make sure that what we discussed prior was aligned and validated, the team will work it through. And they are all medical conversations, right? Really about, okay, the appropriateness, is the coding accurate? So I think a lot of doctors, maybe sometimes it's a lack of precedence or may not have the necessary history on how some of these things are being done. And it's our job to then say, hey, this is what 80 percentile is doing. And then we'll share those information with doctors for them to also self-correct. Otherwise, in private health, everybody is an independent practitioner. They may not necessarily see what's going on outside. And then we take that role and say, how do you harmonize the whole system to make sure that practice are a bit more standardized? So I think that has also helped in terms of getting things to a more consistent stage. Then you talk about other things like facilities. And if we realize that there is a consistently high volume of certain things that's happening in our system, and there's some level of inefficiency in how we have rendered those care, then we will work with the facilities and the hospital to make some optimization. For example, sometimes we roll out packages which help the doctor standardize certain practice and to make sure bills come into a more consistent manner. Predictability is, I think, what everybody's looking for when it comes to how claims come across.
So broadly, what were the most important milestones you reckon that you've achieved?
I think the pleasing and optimistic thing is, of course, the two partnerships that we have. We have managed to bring them to the next phase. And I think this whole process of optimizing costs and being more effective or efficient is an iterative process. I don't think it will ever end. But what we see as a high level, at least in the first phase, you see costs flattening, you see coding practices more standardized, patients who should be in day surgery are in day surgery instead of staying overnight in the hospitals. So many of these episodic cost drivers, I think we have done quite a lot in working with the doctors and working with the payers to have a consistent position on how to manage it. So I think that's what keeps us positive about these partnerships. And I think there's still a lot more to do.
Still to come. Can the partnership between IHH and IP insurers actually reduce or slow the pace at which IP premiums are rising?
Market Focus Weekly, now hosted by Howie Lim. A sharp weekly deep dive into what's moving markets in Singapore and across the region. With analysts and market insiders to break down the forces shaping the week ahead. New episodes every Friday, powered by the journalism of the Business Times. Find Market Focus Weekly wherever you get your podcasts.
And now, back to Wealth BT, a podcast of BT correspondents.
Welcome back. So, Jeffrey, because private hospital IPs threaten to become unaffordable, some insurers now specify hospitals in their panels and exclude your hospitals. So, what do you think about this?
Oh, I think if you look from an insurer perspective, they look at the cost of care being a combination of specialist practice as well as facilities. And over the last few years, a lot of initiatives has happened in the specialist space. You can see there are panels being set up, there are fees being dictated, rules that they have introduced for doctors who wants to be on panels. So I do think the natural way for them to think about is the other half of the equation and what can we do more to manage that a little bit better. But I think there's fundamentally two differences. And when you look at the specialist panel, we have about 1,500, 1,600 specialists in the whole private system, roughly. And if you have a 700, 800 panel, you have a substantial representation, and I think members will be fine with that. But when you look at hospitals, we are a very, very small market. And there are 7, 8 Singapore private hospitals, and IHH has about 4. And the maths doesn't quite add up the same way as how you would like to look at it from a specialist point of view. And I think the conversations with all insurers, even insurers that work with us, there's this conversation about, hey, Jeff, different facilities seems to have different value, and how can we harmonize this better, right? Even the active insurers that we work with think the same. But I guess over time, as we work with them, it's also up to the facilities to demonstrate the value of why they should be working with the insurer. And you look at Singapore, the 8 hospitals. Even for us in IHH, we have 3 tertiary level hospitals where when a patient goes in any of these 3 hospitals, all services can be rendered completely. But we also have a hospital called Parkway East, which is a smaller size hospital in the East, serves a very interesting proposition for the local population. But a hospital of the size clearly cannot run all services. And the fact that it's plugged into IHH means that it can rely on the other 3 hospitals to support and complement that. So it works for us in that sense. And we are thankful because we have a network to support. But if you go beyond IHH, then you look at some of the individual hospitals, I think everybody try to work around their strength and what they do. And honestly, all hospitals in Singapore in private space are somewhat complementary to each other. So my ideal state is to get to the level where there should be no such restriction of access. As I said, conversations with all payers continue. So as a big player in this space, we will work towards opening up, and conversations are ongoing with all payers. I'm hopeful and I believe we will learn something with almost all of them.
So what do you think about this view that because you are scrutinizing potential claims more, letters of authorization, that inadvertently you end up limiting patient benefits?
I don't see it that way, honestly. I don't think the first way of us looking at cost management is about restricting benefits or managing excess in that level. What we are working on right now really is about more consistency, more predictability. My personal view is private healthcare is fairly customized. The experience is important, the speed and access. There is some level of inefficiency that I think we can work better to sort of remove. So I think that's where I feel the first layer of cost and value management should focus on. But of course, there are good practices. For example, if you present yourself to an orthopedic surgeon with some aches and joints, I would say most of the time, a conservative approach of going to rehabilitation should be recommended. But that's good practice. There's guidelines that drive that. So I don't think even for that reason is restricting benefits. So I don't think we are in that position or we want to go to the level where we interfere in the care decisions. And we believe a lot of doctors in our system are responsible practitioners and they will use best clinical practice to guide care. And I don't think the payers or ourselves have any issues on saying, hey, that's not the right thing to do.
So, Jeffrey, what do you see as the next phase of this? And how meaningfully do you think your efforts can dampen bill sizes?
I think it's an ongoing process, Genevieve. From my point of view as an industry as a whole, healthcare fundamentally is a social service. And I think it's important for it to stay accessible. I think the previous years where premiums are rising at double digit consistently is clearly not a good trend. We know that it's reaching pretty astronomical levels in certain age groups, and people are downgrading plans and things like that. So I don't think in the long term that's good for our nation. So our role as anchor player in private healthcare is really to harmonize the systems with the payers as well as the specialists. And our first goal is to level down the inflation. And some of the partnerships have shown very, very moderate increases, which is very pleasing for us and give us a lot of hope that it can be sustained. I think if you have an open platform where you have the payers on board, you have ourselves on board, you have specialists on board, and that's what we do best. We have that platform that we can engage with all stakeholders in an open and transparent manner. And you can align those interests more tightly. So I think that's our position. We think it's an iterative process. With all payers, they all start at different phases of challenges. And we can look at that and say, okay, what can IHH do to help and support that? And I think as you square out some of these challenges, everyone will be more comfortable to be a bit more integrated, to keep things tighter. And hopefully that translates to a very sustainable growth in premiums as well. And then we can all keep our plans. We can all make sure we have access to the facilities we need. And that's where we hope to be.
Thank you, Jeffrey, for sharing your insights with us.
Thank you, Genevieve.
IP insurers actually had a relatively stronger year in 2025 based on my compilation of their underwriting results in the Business Times. But as an industry, profit margins remain very thin. A year of high claims can easily put IPs back into the red. I think efforts like what IHH is doing is welcome, especially if it helps to control costs and claims. For more details, please look up my articles in BT on IP results and what IHH has been doing. That's it for Wealth BT this week. BT Correspondents will be back next week with an episode on transport. This episode was produced by Howie Lim and Chai Pei Chia, together with our editor, Clarissa Montero, and was written and presented by me. Thank you for listening.
This is a podcast by the Business Times. Find more BT podcasts at businesstimes.com.sg/podcasts or wherever you get your podcasts. This podcast is meant to provide general information only. SPH Media accepts no liability for loss arising from any reliance on the podcast or use of third parties' products and services. Please consult professional advisors for independent advice.